to hit record now. So we are going to record this session, and we will be sure to send out the slide deck as well as the recording sometime later this week, potentially early next week, depending on when we get that all situated. So no need to worry, you will get the slides and information that you need to have as a reference. So I'm going to turn it over to Susan. So give me 1 second while I change hands here. So Susan, you are unmuted, and I'm going to have Nancy stop sharing, and Susan, you will be able to go ahead and share.
Great. Okay, thank you very much, Katie.
You're
welcome. And welcome to everyone. Thank you very much for joining us. As Katie said, I'm going to talk about Medicare telehealth services, the coding and billing guidelines in response to COVID-19. I do work with Health-Centric Advisors. We're a nationally recognized nonprofit, and we provide data analysis, education, and technical support to those like yourselves who deliver healthcare. We are part of the iPro QIO along with Clarent, and we work together to ensure high quality health care for the Medicare fee-for-service beneficiaries in the highlighted states. There are two types of QIOs. One is the Quality Innovation Network, and that's what I work in. And we bring together healthcare providers, stakeholders, and Medicare beneficiaries themselves to improve the quality of healthcare for targeted health conditions. The second type of QIO is a beneficiary and family-centered care QIO, and they manage beneficiary complaints and quality reviews, EMTALA violations, etc. The regulatory information that we share today on this webinar is current as of today, but as you know, there have been many coding and billing changes for COVID-19 public health emergency, so please join the CMS and NGS listservs, which you can do on their websites if you haven't already, in order to remain up to date with all the changes. So let's begin. Medicare telehealth services, what are the specifics of the waiver? So the CMS 1135 waiver allowed patients staying at home to receive telehealth services from their providers as of March 6th of 2020. Prior to this, Medicare telehealth services were limited to patients in designated rural areas and when the patient was at a clinic site, such as an FQHC or RHC. And then in 2019, CMS did allow virtual check-ins and telehealth for behavioral health services. But now, the 1135 waiver expanded telehealth to all of the providers listed here and in all settings. And note that the physical, occupational, and speech therapists were omitted the first go round, and then they have been added since April 30th. So other highlights are that providers may work across state lines, regardless of the state in which they're licensed. The services they render may be for all diagnoses, not just COVID-19. The Office of the Inspector General is allowing practices to reduce or waive deductibles or coinsurance. And the E&M frequency limitations on Medicare telehealth have been removed. So this first section, I'm going to talk about physician office telehealth services, so not the FQHC, RHC setting, although some of the information here will be pertinent to you as well. First thing I'm going to talk about are the modifiers. The CS modifier means COVID-19 testing related service. And that is a testing related service actually relates to the E&M service, not the lab test, at which the provider determines whether or not testing is needed, or at the E&M where results are shared. So when you have those types of services, if you add the CS modifier to that claim, then the claim will process at 100% payable. However, the NGS system is not set up to do that until tomorrow. So those claims will process as regular claims right now, and please do not bill that coinsurance or deductible to patients for the testing related services. NGS will reopen, will automatically reprocess those claims starting tomorrow at payable at 100%. If you along the line have missed adding the CS modifier to some of the claims in which you've done testing related services, it's fine to just reopen those claims and add the modifier if necessary. CR modifier has caused quite a bit of confusion. It means catastrophe related service, and that is informational on claims related to the public health emergency. So claims will pay with or without this modifier. However, it does have some coverage related waiver type benefits to it, which we will cover in the next slide. But this relates to things like e-visits and online assessments. You do not need the CR modifier on claims for telehealth, basically audiovisual services, or the services that were allowed prior to COVID-19 public health emergency. So basically, any claims, any services that are on Medicare's telehealth listing, you do not need the CR modifier. However, you do need modifier 95, the telemedicine modifier. This modifier is added to all newly allowed and existing telehealth services, whether they're audiovisual or audio only, for the public health emergency. And those are all on CMS's Medicare telehealth list. Here's more about modifier CR. And this modifier will exclude you from adhering to certain coverage requirements, such as DME replacement. So in other words, when a DME is lost, destroyed, damaged, and it needs to be replaced, this CR modifier will show that you've been able to waive the coverage requirements, such as face-to-face visit, a new physician order, and medical necessity documentation is not required. It also modifies the 60-day limit to allow a physician or a physical therapist to use the same substitute for an entire time he or she is unavailable to provide services during the COVID-19 emergency. The other times you would use that: temporary expansion of locations, end-stage renal disease services in a SNF, and also DME coverage determination waivers for glucose monitors and infusion pumps. There are more of them, and that link at the bottom of the slide will provide you with all of the different times you would use the modifier CR and also explanations of those. So let's talk about the bread and butter, basically E&M codes. All of these E&M services are on CMS's telehealth code list. And then several more codes were added, and several codes were allowed for audio-only interactions as of April 30th. Please note, though, that office visits do still require both audio and visual in order to be payable. Other guidelines are that new patient encounters are allowed via telehealth. It's important to know that you want to bill with your usual designated location. For example, if you usually provide services to patients in an office and you are providing them via telehealth when they're in their homes, you're still going to use Place of Service 11. Even though Place of Service 02 is the telehealth Place of Service code, you would not use that during the public health emergency. Then the reason why is that that Place of Service 02 is paid at a lower rate, what's called the facility rate. And the Place of Service where you usually render services will be paid at the full, what's called non-facility rate. So if you've been billing Place of Service 02, you may reopen your claims and change the place of service, and those claims will be reprocessed for increased payment. Modifier 95 is absolutely necessary and important for any of the telehealth codes on the Medicare's list. If you happen to be a critical access method 2, then you would use modifier GT. And if you do acute stroke services, you would use modifier G0. One thing to know is do not record the telehealth modifier 95 for through window services. So in other words, if your provider is in a hospital location and they're doing a consult or a visit through a window for a patient, for example, in ICU or at any other place in the hospital, because your provider and the patient are in the same physical location, you would just bill that as though it were a face-to-face service or a bedside service. NGS and CMS have said that you may add prolonged services to telehealth E&M codes, but they are pointing us to the non-face-to-face prolonged services. Here's a screenshot of Medicare's telehealth list. It's a simple Excel spreadsheet. And in light of the fact that some patients lack video technology or simply prefer not to be on video, CMS has designated that many services may be billed as telehealth even when the audio-only service is performed, such as a phone call, or if you happen to connect with a patient over Skype or Zoom, but it happens without the video portion. You may still bill those services that say audio only in that column. So as you can see, many of the behavioral health services are that way. The other thing is this spreadsheet has a status column which designates which services have been temporarily added for the public health emergency. And you can see that group psychotherapy is one of those that has been added. And then if there are any coverage limitations, those will also be noted. Here's another, just another screenshot of the behavioral health services that may be rendered audio only, phone or online without the video. And just bear in mind that if you're calling a patient and you're doing therapy, then you would not bill the telephone codes, you bill the therapy codes themselves. If you're calling a patient to just check in and see how they're doing, it's not a therapy visit, then behavioral health providers do have the telephone codes available, and we'll talk more about those in a minute. Again, place of service is where services are usually rendered. You do add the 95 modifier when it's audiovisual or audio only. And again, if rendered by telephone, bill the regular CPT codes, not the telephone codes. Virtual check-ins were covered prior to the COVID-19 public health emergency, and they're still covered now. They are 5 to 10 minutes. Initially, these included phone services per the CMS Dear Clinician letter that came out shortly after the emergency started. But now that phone services are covered, then you would use virtual check-in codes only for email, secure text, or patient portal communications with your patients. You also have a remote evaluation of recorded images service available. And note that if you're in the FQHC or RHC and you provide either of those services, it would just be billed with G0071. Other guidelines to these is that needs to be initiated by the patient. However, practitioners may need to educate beneficiaries on the availability of these services, so that's perfectly fine to do that. Verbal consent is required, and this consent can be just obtained once annually. So if you have a way to track that you've obtained consent from someone, you don't need to get it at every single visit. And also this can be obtained by anyone in the office. For example, if the front office or the nursing staff or care managers are setting up appointments, it's perfectly fine for them to gain that consent. These virtual check-ins have limitations to them. They can't be related to a medical visit within the previous 7 days, and they can't lead to a medical visit within the next 24 hours, or they become not billable. These are for billing providers only, so they're not for nurses or MA visits. There's a couple ways nursing staff can be paid, or clinical staff can be paid for services that they provide. For example, 99211 is on Medicare's telehealth list. So that can be, you can provide a nurse visit. It does need to be audio, visual, both audio and visual. That's perfectly fine. And then the other way that nursing staff can be paid for services to patients are through chronic care management. So if you're not doing chronic care management or complex care management in your practices, please consider that, because I know those are services you're already providing. And I think it's a really beneficial thing for patients as well. NGS clarified that podiatrists and optometrists may bill virtual check-ins. And again, place of service is where the provider usually provides their services. No modifier is needed on these because they're not really considered telehealth, but basically they're not on Medicare's CMS list. So no modifiers needed on these. So e-visits. E-visits are slightly different. These are online digital E&M services. So this would be through your patients, your online portal. The code range is 99421 to 99423. You'll notice that the time is cumulative. So you would want to track these for up to 7 days and then bill at the end of the 7-day period according to how much time was spent. So it's a little cumbersome to track these and bill them out, but it is available to you. Place of service is where the physician usually provides services. You would add the CR modifier to these because these are covered only for the public health emergency and they're not on the CMS telehealth listing. So they don't need a 95 modifier. These are billable in the FQHC, RHC as well when you work with a patient on the, via the online portal, but it's billable with your G0071. There have been a lot of changes to telephone services, a lot of good changes, I think. So telephone services by physician actually include all of these provider types. They include the MDDO, podiatry, optometry, dentistry, and then also your ancillary providers, your nurse practitioners, PAs, and nurse specialists. They are, you have to keep track of time, document time for these codes. The payment rates initially were about $14 to $41 for this code range, and then Medicare increased it to around $46 to $110, and they made that increase retroactive to March 1st. So the important thing to know here is to raise your fees in order to be able to capture that $110. NGS will automatically reprocess submitted claims, but if you aren't charging enough to capture the new payment amounts, then you'll need to reopen your claims via NGS Connects or Connex or the LVAM in order to raise your fee. So just to be clear on that, say for example, you were charging $25 for 99441, and in March, some claims processed payable to you at $14. When NGS reprocesses those, they'll pay you $25 instead of the $46. So it's important to go in, as I said, and increase your fees so that you can capture the larger amount. Other great news about these is that the limitations, the frequency limitations have been removed. They used to be billed only every 7 days, and they couldn't be related to medical visit within the previous week and couldn't lead to a medical visit. That all of that has gone away. And Medicare's statement to us is The only associated frequency limit is the long-standing rule of no more than one service being billed per day. So when repeat services are necessary for follow-up or a new problem, these services may be performed as frequently as is necessary for patients' care and safety. And I just think that is excellent news for everyone. The established patient rule is waived for COVID-19, and only E&M billing providers may use these codes. So that's important to know. Place of service is where the physician usually provides services, and you would add modifier 95. These are on the Medicare list. So these are the telephone services non-physician. And you'll notice that the ancillary providers, NPPA and nurse specialists, and optometry are also included in this code range. So they really have the choice of which service they would like to bill. Well, obviously there's many advantages for them to use the physician type telephone services. But these services are available for psychologists, PTOT speech therapists, and LCSWs. Initially, Medicare did include nutrition professionals on this telephone services code range, but they've since removed that with the guidance that they want the nutrition professionals to use the codes that they would normally use within their scope of practice, such as the GO108 or medical nutrition therapy. They want them to bill those services rather than these telephone codes. The frequency limitations were not removed from this code set. So again, these can only be billed once every 7 days. If you have an LCSW in process with a patient, then you want to make sure to add the time together for the 7-day period and bill the highest code that you can. These, again, must not be related to the surrounding medical visits. And the rest of the guidance is pretty much the same. No modifier CR or 95 is required because these are not on the CMS list. If a physical therapist uses these codes and you're working within a plan of care, please use the GNGO or GP modifiers. I included a slide here on annual wellness visit. I love the annual wellness visit. I just think it's a wonderful time for providers and patients to connect and talk about wellness, and instead of focusing so much on disease. And I also think it's a time when people can plan for how they want to live their lives or lifestyle changes they might want to make. If your providers have the bandwidth now to do annual wellness visits via telemedicine, I think it's an excellent time to check in with beneficiaries to see how they're coping with the pandemic, monitor their health status, provide referrals for any food insecurity they might be having, and also to take a look at depression and anxiety, see how they're handling all this, and to support their self-care. These now may be rendered audio only if necessary. And please note that the initial IPPE is not, cannot be done via telehealth, but the initial and the subsequent annual wellness visits can be done, annual depression screening. This might be a great time to talk to patients about advanced care planning, although I would probably recommend that you just discuss it briefly and then reschedule a time to go over in more depth the annual advanced care planning, and that can be done via telehealth. You would document your usual AWV components, create a preventive screening list, even though you may not wish to schedule screening at that time. Send a copy of the care plan to the patient, give referrals as needed, set up any follow-ups necessary. And please note that the vital signs are optional for the public health emergency, and also providers can take self-reported vital signs. you would add modifier 95. If an acute visit is needed at the same time and you're on audio-visual, you can go ahead and also render an acute visit. You would just add a modifier 25 and a 95 to your E&M code, such as 99213. Wanted to say a word about consulting services, physician to physician. If you're performing physician to physician services, this is the code range to use for a discussion and a written report on the top left. If you do a written report only, then you would use 99451. If you're the treating physician or QHP, qualified health professional, and another provider wants to know information about baseline or whatever, then you have available the 99452. These are not generally covered, and they're not on the CMS telehealth list, so these would require a CR modifier. Now on the right-hand side of the slide are the telehealth consult codes. These are on the CMS list, and these can be audio only. You would add the modifier 95, and those are the code ranges for the ED inpatient, follow-up inpatient, and critical care consults. PTOT and speech therapy got off to a little bit of a rocky start with being omitted from the provider list, but all of the therapy services and the providers were added as of April 30th. If you provide therapy services, do add the modifier 95. These are on the list. Use your usual and customary place of service, and be sure to add the GN, GO, or GP modifier. Physical therapists also may bill those telephone codes we talked about and these online assessment codes. The online assessment codes are when you're basically not doing therapy, but you do want to do an assessment with the patient. And these are cumulative times, so they're billed only once every 7 days, but you can add the time together and bill it all at once. Now let's talk about the federally qualified. On the left, you see that the Secretary's statement saying that for the public health emergency, telehealth services would be paid for FQHCs and RHCs to provide them to patients who are either at home or in a different setting. And that's very new. Previous to that, as you know, FQHCs and RHCs were not able to provide services. They were just able to be the site where the patient could receive telehealth. But now that's changed. The billing guidance was a little bit uncertain for a while, but through June 30th, through today, this is how those services are billed. The FQHC would enter the G code for their encounter, G0466, for example. Then they would add the telehealth list for CPT code, such as 99214 for an office visit with the 95 modifier. And then they would add a brand new code set up for RHC and FQHC telehealth billing, G2025 with a 95 modifier. For the RHCs, they would bill the CPT code from the list, such as 99214, with CG and 95, and then also the G2025 with the CG modifier. Now these claims may not pay until July 1st when the system updates, but they will eventually be adjudicated. So as of tomorrow, the billing for FQHC and RHC gets a lot simpler. You just use the G2025, no modifier for the FQHC. And actually no modifier is really needed in the RHC either. They're saying that 95 modifier is optional. Please remember to add the CS modifier on the service line for any testing related services, because that way the coinsurance and deductible will be waived. And there's the claim type and the rev codes to use. Also, the payment initially will be or was the AIR or PPS rate. And then for telehealth services, the new reimbursement rate will be $92.03. Any previous claims with the 95 modifier will be reprocessed for the new payment. Here's that virtual check-in that can be used, the G0071, again, initiated by the patient. However, you may educate patients that you have this service available. This will be paid at the new rate, retroactive to March 1st. It will pay at $24.90. So again, make sure that you're charging enough to capture the reimbursement for this G0071. And NGS will automatically reprocess those claims. These do have the stipulation, as we spoke earlier, previous 7 days and no visits within the next 24 hours. These can be billable alone or with other payable services. And there's the claim type. No modifier needed in the FQHC. And I was unable to really nail down whether or not a CG modifier is needed in the RHC, so it's probably a good idea to go ahead and include that. All right, let's talk a little bit about documentation. Because there are so many visit types now with telehealth, as you can see, it's important for providers to state what type of visit they're providing, so it will back up the coding. So is it an office visit? Is it a PT session? Is it an annual wellness visit? Is it a phone call? Also, I think it's important to also state how the service is being performed. Telehealth, is it audio visual? Is it audio only? Are you using Skype? Are you calling the patient? I think it's important to frame that visit as accurately as you can. You do want to state that the patient has consented to the visit. We talked about that earlier. That's needed annually. You want to identify who is present on the call or in the encounter and what their role is. Is there a caregiver there or a family member? If you're doing services in the nursing home, the nursing staff that's present to help you facilitate the visit. And then mention the location of the patient. You would add your usual documentation criteria, and then be sure to add time spent if it's a time-based code. And you can either enter your total time or you can enter stop times will work just as well. I wanted to talk a little bit about telehealth facility billing. This is the facility code. It's Q3014. And this is billable by a facility where the patient is located. One big change that has happened, CMS has said that a provider-based hospital may bill a facility fee for registered outpatients who receive services from home via telehealth. So in other words, if you have a cardiac rehab program, physical therapy program, or dietitian services, the patient is registered as an outpatient with you and you're in this ongoing process, the provider-based hospital may bill the Q3014. You would use either the CR modifier or DR modifier, depending on hospital status. For nursing homes, a staff member will need to facilitate the telemedicine experience between the patient and the clinician, managing the technology on site, and also perhaps providing some HPI, some history of present illness, other types maybe providing vital signs, things like that. Nursing homes do not need to apply for a waiver to use telehealth. The important thing to know is that Q3014 is not allowed in SNF type of bill 21X, but it is allowed on a type of bill 22X or 23X, which is a SNF Part B stay. And there's the link to the processing manual that outlines that for you. Next, we'll talk about testing and treatment services. These are the diagnosis codes to use for COVID-19. They were created effective April 1st of 2020. Initially, CMS was denying screening diagnosis codes, but they now will cover them. And they'll also cover Z11.59 for pre-op screening. So that's good news. NGS is going to do a mass adjustment of those claims. Prior to April 1st, the only code available to use was the B34.2 unspecified coronavirus. As far as specimen collection goes, if you are a lab or a home health agency, you would use the G2023 or 24 listed there on the left. The G2024 is applicable to patients in a non-covered stay in a SNF and not to those residents in Medicare covered stays, just so you know. If you're a hospital outpatient department, you would use C9803. And in a physician office, you may bill specimen collection as a nurse visit, 99211. You would add, of course, the CS modifier to that for a testing related service. So you would be paid at 100% of the fee schedule. And FQHCs and RHCs may not bill for specimen collection. These are the lab tests. If you're billing Medicare for COVID-19, these were effective April 1st. If you're sending the test to CDC, it is the U0001 that does not need a CLIA waived modifier of QW because it's going off-site to be processed. But effective 3/20, you do have to have the QW modifier on tests you do in-house, the U0002, or those will deny. So it's important to reopen claims to add the QW modifier. If you're billing other payers, a brand new code was also developed, and it's 87635. That does need a QW as well. And that has a CPT assistant for this new code, and there's a link provided there so you can take a look at that. These are brand new for antibody testing. They are effective April 8th, but they won't be included in the system until tomorrow actually, the 2020 release. So you can hold your claims, or you can submit your claims and NGS will hold them and process them starting as soon as the system updates. They're 86328 QW and 86769 QW. And I don't know if these are still in use for treatment, but I'm sharing these. Because they were created in March, effective April 1st, for treatment for COVID-19, and these are those injection codes. So this is our slide that has all the resources on that. Included here is the Medicare Telehealth Guide, QuinnQIO, and that's a guide that has much of this same information that I've shared today. Plus it also has a whole section on remote patient monitoring, which might be something that you're beginning to do now that so many patients, you're managing so many patients as they remain at home. This is a link to our guide, and as changes happen, that will be updated. And the rest of those are NGS and CMS resources. I want to thank you for joining us, and I want to give you a big shout out. Thank you so much for all you do and for our Medicare beneficiaries and all of the patients. So thank you from the bottom of our hearts. And thank you for participating in the webinar. And now I'll turn it back to Katie.
Thanks, Susan. You can go ahead and stop sharing, and then we'll have Nancy Del Mastro share her screen. So while we wait for this transition, Susan, there are a few questions that came up in the chat. If you want to, while I'm presenting, go through and address those, or we can hold them until the end. But now we're going to switch gears a little bit, and we're going to go into Medicaid billing for New York State. So just as a quick disclaimer, similar to what Susan said, we are constantly seeing updated information as it relates to COVID-19 billing, extensions of public health emergencies, what will or will not remain. So please take today's information as accurate and reliable for today, knowing that it could change. Let's fast forward 2 slides and we'll dive into Medicaid. So as most of you on the line likely know, the New York State Department of Health released a very comprehensive guidance document as well as an FAQ document regarding the use of telehealth, including telephonic services during the state of emergency. A quick update on the state of emergency. So last night, the Department of Health and Human Services extended the public health emergency another 90 days. It was set to end on July 25th. That has been extended. Now that's at the federal level. We are looking for information around what that means for New York State and if they will follow suit. So more to come on that. But for right now, for dates of service after March 1st, New York State Medicaid is reimbursing telephonic assessment, monitoring, and E&M services whenever possible. And that is covered for any service provider or qualified practitioner as it's considered medically necessary. Next slide, please. Looking at the definitions of telehealth and originating in distant sites, you will see in italics here that for the purposes of the state of emergency, some of those have changed. This definition of telehealth now includes telephonic, telemedicine, including teledentistry, store and forward, and remote monitoring. There are no limits on originating sites, no limits where the patient is located, and there are no limits on the distance site either. Clinic providers can work from their homes or any other location within the 50 United States or United States territories. Next slide. In terms of confidentiality and consent, the Department of Health and Human Services Office for Civil Rights did issue a notification of enforcement discretion for telehealth, meaning that OCR will exercise its enforcement discretion and not impose penalties for noncompliance with HIPAA rules. That means that platforms such as FaceTime, Facebook Messenger, a few others, consumer-facing Skype are allowed right now. However, we have been consistently recommending that you explore HIPAA-compliant platforms whenever and wherever possible. In terms of consent, written consent during the public health emergency is currently not required. Verbal consent will suffice. You just need to make sure you take all reasonable steps to ensure privacy during interactions. If a patient is in their home, that of course means advising them to go into a room that is quiet where there aren't other people around, making sure they have a good connection if possible, things like that. Next slide, please. Now I want to show you the telephonic reimbursement billing grid that was set out by New York State Department of Health. There are 6 lanes. This chart has 2 basic sections. Lanes 1 through 2 are for use by fee schedule billers. So that's primarily practitioners in office-based settings. And lanes 3 through 6 are for all other billers that primarily bill rates for clinic and other services. Practitioners that usually bill the fee schedule directly should bill for telephonic services using lanes 1 and 2 based on the practitioner types noted in the applicable providers column. Clinics should bill using lanes 3, 4, and 5 depending on FQHC status and practitioner type. Changes made in May are noted in bold. This includes the addition of the place of service code and modifier columns. A few changes that are worth mentioning include that 99211 is for telephonic services delivered by a nurse on staff, billed under a practitioner that can bill Medicaid, and you would use the GQ modifier for tracking purposes. Additionally, you'll see under lane 1 that codes 99441 to 99443 are your telephone E&M services based on time spent, and the reimbursement rates for those have increased. Lane 3, 2 rate codes were added, and clinics should report the appropriate CPT code for the service provided, i.e. 99201 to 99215. Modifiers are not required. And lane 4 changed the telephonic service column to note FQHC off-site licensed practitioner services, which now include social workers and psychologists, and that RAP payments are available for these listed rate codes. No modifier is required. Next slide, please. So here we have lanes 5 and 6. Lane 5 is for clinics, non-licensed practitioners, and FQHCs, and should be used for any and all patient assessment and management services that are appropriate to be billed telephonically. Lane 6 is reserved for all other services that do not fit into the first 5 lanes. It is worth mentioning again, telephonic services should only be used when audiovisual is not possible. Next slide, please. In terms of telemedicine, so your two-way audiovisual, the modifiers have not changed. It's still you're still going to use your 95 modifier for services covered by Medicaid and listed in Appendix P of the AMA CPT Codebook from 2018. You'll use GT for codes that are provided via synchronous telemedicine, for which modifier 95 cannot be used. You'll use GQ not only for the 99211 nurse telephonic services, but also for store and forward or asynchronous technology. And the 25 modifier is identifying a significant and separately identifiable E&M service by the same physician or other qualified healthcare professional on the same day as another procedure or service. When you're billing for teledentistry, modifiers cannot be used by dentists. There are 2 codes listed on this slide that can be used in place of modifiers and billed alongside the Q3014, which has been added to the dental fee schedule. All other billing rules that have been in place for the last several years remain the same, and you would want to refer to the DOH Medicaid update for specifics. Next slide, please. Looking at Medicaid managed care plans, these plans are required to cover at a minimum services that are covered by Medicaid fee-for-service and also included in their benefit package. They must also provide telehealth coverage. Absent any existing state mandated rates or negotiated rates for telehealth or telephonic services, these plans must reimburse network providers at the same rate that would be reimbursed for providing the same service via face-to-face. So that's your payment parity. We've been looking for that for a long time. During the public health emergency, these plans do have to cover telehealth and telephonic services at the same rate unless otherwise negotiated. These plans may not limit member access to telehealth or telephonic services to solely their telehealth vendors. They also need to cover telehealth and telephonic services provided by in-network providers, not just your Teladoc or your Doctor on Demand or your MD Live. They have to cover that, but they also need to cover telehealth services provided by your providers. When in doubt, reach out to the member's plan representative to confirm what rates are, what is or is not covered. Next slide. Looking ahead, this is the million-dollar question that we keep getting is what will happen in the future and what flexibilities and waivers will remain. Is still unknown in terms of what the future will look like when lifting restrictions. We did see, I think it was a week and a half ago, that the governor signed into law both a Senate and Assembly bill, which now provides reimbursement going forward for audio only and video only telehealth telemedicine services. So while we've had reimbursement for telemedicine, We are now going to, absent of a public health emergency, if that goes away, we will still see reimbursement for audio-only telehealth when it comes to Medicaid. So that is a huge win for New York State, and it's the first sort of glimmer of hope for what the new future may look like. I'm seeing a lot of activity on the federal side in terms of different committees and legislators signing on to letters or petitions or recommendations regarding federal waivers that will remain. But at a state level, you can certainly expect that we will see some changes and that things may not look the same as they did back in January. If you ever have questions for DOH, I have put an email at the bottom. It's telehealth.policy@health.ny.gov. You can direct any questions related to their policies to that email address. So let's move on to OPWDD. So OPWDD, also for the public health emergency, they are encouraging all non-residential facilities and programs that are certified or operated under OPWDD to deliver telehealth services to individuals with IDD wherever possible. So that includes health and habilitation services, you know, and where a service or support requires a physical presence of a staff member, it may not be appropriate, it is not appropriate to be delivered via telehealth. Next slide. So this is OPWDD's definition of telehealth. Of course, it's your two-way audio visual. They are allowing telephonic modalities to be used in limited circumstances if telemedicine is not an option. Certain health, habilitation, and respite services are permitted for telemedicine. However, in terms of telephonic, respite services cannot be provided with telephonic. It has to be used with telemedicine. Next slide, please. A few billing guidelines for OPWDD. You know, telehealth services shall be delivered by providers that are acting within their scope of practice, exercising good clinical judgment, and practicing in the appropriate use of telehealth with respect to the service. Reimbursement is going to be made in accordance with existing Medicaid policy related to supervision and billing rules and requirements. For providers that offer habilitative or respite services via telehealth, the agency or entity has to be certified or operated by OPWDD. Direct support professionals and other staff members who are not licensed or certified, but are authorized to deliver a service by the agency they work for, may deliver habilitative and respite services via telehealth as a staff member of the OPWDD certified or operated provider. The provider will bill Medicaid for those services that are delivered by staff members who are not licensed or certified themselves. Additionally, for the duration of the emergency response to COVID-19, providers delivering services as independent practitioner services for individuals with developmental disabilities, or IPSID, can use telehealth and bill at the IPSID rate. That wasn't previously allowed, but for the duration of the public health emergency, it is. Next slide, please. So OMH. Certain regulatory requirements applicable to telemental health services, including requirements for the written approval process, policies, and procedures, have been waived. In addition, the definition of telemental health for Medicaid reimbursable services has been expanded to include telephonic and video. OMH guidance has largely stayed the same since the March updates, but we do keep an eye out on any updates that are happening. So this supersedes any other state-issued telehealth guidance and only applies to OMH licensed and designated programs and services. This guidance does not apply to private practitioners. It applies only during the declared state of emergency, which as for now, as far as we have seen, is until July 6th of 2020, so Monday. I imagine that we will see some sort of message or statement on an extension or otherwise. Haven't seen anything yet. Next slide, please. So in terms of this expanded guidance and self-attestation, you know, the self-attestation really applies to telemental health practitioners and agencies that operate under OMH. You would submit your self-attestation to Amy Smith at OMH. I have shared that email in the past. If anybody needs that, I can share that. Once you submit that self-attestation, you are good to begin providing services. You do not need to wait for a confirmation. You will want to save that email you receive back though. You're basically certifying to the following: that your providers possess a current and valid license, permit, limited permit, or other credential to the extent required in New York State to deliver telemental health, that your transmission linkages will be dedicated, secure, and meet minimum federal and New York State requirements. You will maintain confidentiality, and that you will use 95 or GT claim modifiers on each claim line representing a service via telemental health. Next slide. So these are some of the licensed and designated services that this would fall under or apply to. Your Article 31 clinics, ACT and PROS programs, Children's Day treatment, HCBS, so on and so forth. There's no change in reimbursement rates or methodology. Providers can deliver any service appropriate for individuals to receive via telemental health, which include individual, group, and collateral services, clinic integrated outpatient services, and clinic-based intensive outpatient program services. Next slide, please. Excellent. So of course, as I mentioned on the first slide, telemental health for Medicaid reimbursable services now includes telephonic as well as video, including technology commonly available on smartphones and other devices. A telemental health practitioner includes any professional, paraprofessional, or unlicensed behavioral health staff who delivers a qualified service. Verbal consent is allowed during the public health emergency. Providers of telemental health services can collect consent for services verbally so long as the consent is informed and recorded by the provider in the patient's treatment record. Providers should also be advised that in subsequent in-person appointments that occur at a later date, written consent from the patient should still be obtained. Next slide. So again, services can be delivered through telephone and or video using any staff allowable under current program regulations. So long as you're using claim modifiers 95 or GT on each claim, representing a service delivered via telemental health. This also includes telephonic only services. Providers should indicate in their documentation that the service was provided telephonically or via video, and that you can deliver any service appropriate for individuals to receive via telemental health. Next slide, please. A couple of helpful resources as it pertains to OMH are on this slide. They have also created a very comprehensive FAQ document with a section just dedicated to telehealth. The self-attestations, if you have not yet submitted one, can be directed to Amy Smith's email, which is at the bottom of this slide. Next slide. And to wrap things up, we're going to talk about OASAS and then get into our Q&A. So thank you for hanging tight with us. So next slide. Similar to OMH's telemental health guidance, OASAS issued telepractice guidance that supersedes any other state or federal telehealth guidance and applies to OASAS certified and otherwise authorized programs and services, so long as you submit a self-attestation. This applies during the declared state of emergency. We are still working on confirmation of this date because we've seen September 2nd and we've seen July 6th. When we reached out to our OMH and OASAS contacts, we were told to stick with the July 6th date. So I know this says September 2nd, but we only know right now that Executive Order 202 is for July 6th. We did receive a question in the Q&A about nursing visits. We are talking about New York State OMH and OASAS here, so I don't know if nursing visits would really apply in this situation. We're talking about telemental health and telepractice only. Susan, I don't know if you have other thoughts on the executive order and what happens as of July 7th in terms of nursing visits, but maybe you can pop into the chat. Next slide, please. So again, OASAS has also put forth an expedited approval process. As a reminder, this also does not apply to private practitioners. You would complete a self-attestation form and send it to the email on this slide. Your approval occurs upon submission of that attestation. This approval is time limited and effective only during the disaster emergency. If you've already been designated to offer telepractice services through OASAS, you do not need to seek additional approval. A couple of other things that if you're considering offering telepractice services, I say telepractice and not telephonic, telepractice services beyond the public health emergency, you may want to start putting together your policies and procedures to submit attestation once the public health emergency is over. And our team at AHI can work with you on that process. Next slide, please. So telepractice for Medicaid reimbursable services has been temporarily expanded to include not only telemedicine, but telephonic communication. The client and or practitioner can be at any site that meets with privacy and confidentiality standards, including a home. And the space utilized for a telepractice session should assure privacy and protection of patient confidentiality. Services that can be delivered are those allowable under current program regulations or state-issued guidance and include assessment, individual, group, medication management, and collateral services. Next slide. So one of the wins for New York State and OASAS that happened in mid-March was that peer services delivered by SERPAs became allowable to be delivered via telepractice. It's allowable by providers who have submitted the attestation though. Additionally, assessment, counseling, and other non-medical services may be provided using telepractice by unlicensed staff, case actees, and individuals who possess a limited permit. You would bill in the same way that you usually bill, the only additional requirement being the inclusion of your 95 or GT modifier and a place of service code of 02 on Medicaid claims. Next slide. OASAS technology requirements. So I had mentioned earlier that OCR was not enforcing HIPAA during the state of emergency. The Department of Health and Human Services did provide a list of vendors that represent they provide HIPAA compliant video communication products and that they will enter into a BAA or business associate agreement. So of course, some of those HIPAA compliant vendors include the ones listed on this slide. So while acknowledging this relaxing of enforcement, OASAS providers approved for telepractice need to make every effort to utilize HIPAA and 42 CFR Part 2 compliant technologies. Informed consent continues to be required. While written consent is of course preferable, verbal consent is permissible when it is the only available option, provided that the program notes this in the patient record and follows up with a written consent at the earliest possible convenience. Consent only needs to be documented once, while each encounter conducted via telepractice must be documented in the patient record. Group sessions can be conducted through telepractice through many of the available platforms on this slide. Telephonic group sessions are also permitted where a provider is able to verify the call-in was not distributed to anyone not invited, has obtained consent from the participants, and has a plan for how such sessions can be conducted to ensure meaningful participation by all. Next slide. So telepractice and controlled substances. So the DEA has issued guidance waiving the requirement of a face-to-face in-person medical evaluation with a patient and DEA registered or data waive practitioner prior to prescribing controlled substances. A prescription can now be issued when the practitioner and patient have a telepractice session that is conducted using telemedicine. Telephonic only communication is not sufficient. So thus the practitioner may issue a prescription either electronically for schedules 2 through 5, or by calling in an emergency Schedule 2 prescription to the pharmacy. Next slide. So a slightly different federal regulation here with the Ryan-Haidt Act. This differs from the previous slide, and I'll note how. So CMS has temporarily waived provisions of the Ryan-Haidt Act to allow practitioners to schedule and to prescribe Schedule 2 through 5 controlled substances via telemedicine without an in-person medical evaluation, provided items 1 through 3 are met. So OASAS is requiring telemedicine, but the Ryan-Haidt Act will now allow telephonic, so long as the prescription is issued for a legitimate medical purpose. So if you are in New York State operating under an OASAS license, you need to use telemedicine, not telephone, even though the Ryan-Haidt Act says it's allowed. Next slide. Here we've included some helpful links for OASAS, including their COVID-19 resource page. They have also come up with an FAQ document. OASAS has even come out with a Telepractice informed consent document. That is a document that you can download and utilize for your own telepractice program. So that wraps up our presentation or content that we wanted to present today. I'm going to unmute Susan, or she can unmute herself, I'm not entirely sure. We will take your questions. I see Susan has been answering some of these in the chat, but if you have any questions for Susan or myself, please put those into the chat box now. Susan, I don't know if you wanted to address any questions verbally that you hadn't answered yet in the chat. I haven't been watching the chat.
Sure, thank you, Katie. The only thing I will say is that I have not heard anything about extension beyond the public health emergency, and I have not heard any end times for the public health emergency for CMS for Medicare billing. I will say that a communique came out the week before last about home health agencies being able to continue to provide telehealth visits as part of the home health plan of care after the public health emergency, and I thought that was really great news, and hopefully that's the beginning of a trend, because I think telemedicine is so important and valuable for all of us.
I agree, and you know, like I said earlier, we've been getting a lot of questions around what will or will not be allowable when the public health emergency ends, and we just don't know yet. It's going to take some time. I will note that there is a difference between regulation and legislation. Regulation is where CMS can exercise their regulatory authority to keep certain flexibilities in place, whereas legislation is a little tougher and typically requires an act of Congress. So a few examples of what regulatory flexibilities currently fall under regulation versus legislation. The American Hospital Association actually came out with a really great document on this. Regulation would be required for things like providers offering telehealth from their home to remain, direct supervision via telehealth, additional codes listed on the physician fee schedule to remain, and payment parity. So that's where regulation would allow those things to remain. Legislation is a little bit tougher, and a few caveats there include the geographic and originating site requirements under CMS, FQHC and RHC serving as distance sites, audio-only communication, expanded eligible provider list. Those fall under legislation where they would remain. So it will be interesting to see in the coming weeks and months where everything falls in terms of what will or will not remain. We are certainly advocating with our state and federal contacts to have as much stay as possible. We've already seen a huge win in New York State with audio-only telephone services continuing to be reimbursed for the future. So of course, you know, it remains to be seen what will happen. Susan, I don't know if you have any additional thoughts on that.
No, thank you for that. Felicia has asked a question in here that I think might be more pertinent to you, Katie, because it talks about the New York State law. Do you see that question in the chat?
I do. So that's referencing the audio-only bill that was signed into law about a week and a half ago for telephonic reimbursement and what that might look like for FQHCs. Any literature I've seen on this bill so far just says audio and video only telehealth services. They don't go into eligible or ineligible sites yet. So I don't have that information right now as to whether or not that would have any implications for the FQHC world. We'll continue monitoring that and certainly advise our FQHC partners if we see anything that changes the landscape for them, but I haven't seen anything yet about that. Erica asked a question, is this law just for DOH services or does OMH get included in that as well? I do see my OMH contact on the line. I don't know, Amy, if you want to hop in the chat and confirm. This is for Medicaid and CHIP, so I can't confirm if this would trickle into OMH, OASAS or not. Amy, I can unmute you too if you want to actually talk about it. I don't know what you may or may not know. It's not letting me unmute you, but feel free to pop into the chat if you want to confirm. Sometimes we have to just wait to see what will come out from our other O agencies as to how they plan to follow whatever guidance or bills have been passed. So we'll see if we get any confirmation on that. It looks like, Susan, you answered every other question in the chat, addressing some of the concerns around Q3014, place of service, and things of that nature.
Right. There was one question that I didn't know the answer to, and that is if place of service 22 is used in the provider-based environment, will that process with the facility portion, or should they add the Q3014 in order to capture that? And I apologize, I don't know the answer to that question. It's an excellent question. Mm-hmm. I will research that a bit and I'll update the guide that is on the link to the iPro site when I do find that answer.
Yeah, I haven't either. Only guidance I've seen around place of service codes is to, I mean, you can still bill place of service code of 02, but you're not going to get as much reimbursement as if you put an 11, a 12, or a 22 on there, where you would have seen that patient in person otherwise. So whether or not you can or can not bill with Q3014, I haven't seen anything either.
Right.
Just when we think we have everything covered, there's always a situation where we don't have an answer, because there are so many nuances to billing and coding, especially when it comes to telehealth. And you know, things are still changing. And now we're seeing changes in terms of what will or will not remain, when is the deadline. But we're just trying to research as much as possible. So if you have any other questions, we still have about 10 more minutes to take your questions. Susan is a really great resource when it comes to billing and coding for telehealth. So now is the time to ask.
Great, thank you.
Yeah, we'll just wait another minute or two to see if anything comes in. And of course, we will be sending out the full slide deck as well as the Health-Centric Advisors Telehealth Billing Guide, as well as the recording by the end of this week, hopefully around Thursday. And for anybody who isn't already aware, AHI did come out with a Telehealth Technical Assistance Center website. I will put the link to that in the chat. So if you want to check out our new site and some of the features on there, we would love to get your feedback. It is worth mentioning that the interactive provider map that is on that site is currently limited to the 9 counties that AHI serves due to some grant funding in the back end. But it is my hope that in the future we can expand that to include telehealth locations all over the North Country and beyond. So no other questions have come in, Susan, so I'm going to say that we can wrap it up a few minutes early. Thank you, Susan, for your time and expertise today. I feel like I learned something too, very detailed information that will be helpful. Again, my contact information is on this slide, and if you would like to get in touch with Susan, please send me an email and I can facilitate that connection. Thank you for attending today. Thank you, Susan, and we will catch you on the next educational webinar. Thank you.
Great. Thank you so much. Bye, everyone.
Bye-bye.